sharp as a system, and including Coronado Hospital especially, you guys are pretty far ahead of the rest of the country. So there are 7 sites across the country that we call total program excellence sites, and entire hospital teams from around the country will come and observe to see how you guys do things. So a big part of the DaVinci, what we call ecosystem, is it's more than just the robot. It's all the other stuff, courses, offerings, teachings, and access surgeon data, all that sort of stuff. So I printed off these articles before I jump into the robot itself, and it's talking about total program excellence, which is something that you guys are definitely a part of. And it just sort of goes over how the robot can help achieve consistent care for patients regardless of who's there in an academic hospital, all the way to sort of big city, rural, etc. And it talks about all the offerings for surgeons as well as surgical teams, including like apps that measure their data, their time, surgical instrument usage, how they can reduce costs, how they can maybe be more efficient if they're not using something, how they can streamline staffing if needed, if there's a shortage, stuff like that. So if you guys want to read it, you're welcome to. But there are 3 components to the DaVinci Xi. So over there in the corner, you have what's called the surgeon console. So that's where the surgeon sits. They have a 3D image through those little goggles there, and then they control the instruments with hand controls. You can't really see where you're sitting, but they essentially stick their hands into the controls, and they can operate the instruments sort of like their wrists. So the instruments are actually wristed further than the human wrist, and they're seeing in 3D, and it's 10 times magnification. So they're seeing very close up to the anatomy, which allows for pretty precise dissection. So the pillars of the robot, surgeon autonomy, precision, and vision. So vision, like I said, 3D, super close up. It allows for precise movements. These instruments are extremely small, wristed, surgeon has complete control. And then the autonomy. So surgeon controls all the instruments as well as their cameras. They can fire cautery, they can suction irrigate, they can staple, they can do all of that all on their own, which allows them to give the same operations to patients regardless of who's bedside. So if they come in the middle of the night to do a procedure, it's the exact same procedure as it would be in the middle of the day, because it's not dependent on maybe somebody who does a lot of robots, doesn't do a lot of robots, something like that. Okay? So I'm going to pass this instrument around. Careful, it is sharp. But I just want you guys, you can kind of bend it, play with it. I want you to see sort of what the instrument is like and how the surgeon is able to control it. The other instrument I'm going to pass around is our stapler. It's called a Sureform stapler, and the reason I brought that is the surgeons here do a fair amount of bariatric surgery, so Dr. Morris especially, he uses our stapler in sleeves or bypasses. And what makes that stapler unique is not only its wristed articulation, so it can bend 60 degrees in all directions, which allows them, instead of having to move the tissue to the stapler and kind of pull tissue, they can move the stapler to the tissue, so it's less traumatic. But it also puts a computer in between the surgeon and the tissue. So as the surgeon's firing, the robot is measuring the compression that's needed in order to make a perfectly formed stapler. And it's measuring it throughout the firing process. So if ever the robot realizes that the pressures needed to compress the tissue adequately are too high, it won't continue firing. So there's basically no way for a malformed staple to happen with this stapler. It won't let it happen with robot. So it's used a ton here, and that not only prevents leaks, prevents oozing, allows a surgeon to size their staple loads correctly, which is really important on like a sleeve or a bypass when they're connecting two pieces as well. Okay, the other thing that we talked about a little bit, the precision. So these are the cannulas. These go directly into the patient's body wall. This thick black line sits in the muscle layer. So this is a normal size cannula. We also have bariatric lengths for people whose abdominal wall is maybe a little bit thicker. And when the surgeon inserts this cannula, this thick black line is going to be a fixed point in space. So this robotic arm moves around the fixed point in space, meaning where that thick black line is doesn't move. So if you think about me putting this through a piece of paper, if I slam this through, as the cannula moves, if the paper is sitting right where that thick black line is, the hole's not going to get any bigger because it's not moving. But if you slide it in far and it moves around like this, then it'll create a bigger hole, a risk of herniation post-op. So one of the reasons that a surgeon may find that their patients have significantly less pain is this operating in a fixed point of space. The robot's ensuring it's not going in and out. So it reduces post-op pain as well as the risk of herniation. A lot of surgeons surgeons talk about that. Do you guys have any questions about the setup, how it works, the system, the kind of flow of it? If not, we'll move over to where the surgeon sits. Any questions?
Why are 3 drapes instead of the 4th one?
Great question. So a surgeon can opt to use 3 or 4 arms, or they can use 2 arms or 1 arm, whatever they want. All of the instruments and all of the cameras can go in any of the arms, so they can switch if they want. In this scenario, if you look on the screen, we have 1 arm for the scope, we have a Maryland bipolar forceps in our right hand, and we have a vessel sealer in the left hand. If a surgeon would like to put in a 4th arm, they can use that 4th arm for static retraction, or maybe they might put in a suction irrigator. So for more complicated procedures, or procedures where, like a gallbladder, where they have to hold the gallbladder up as they work underneath, they'll put in a 4th arm. And as they sit at the console, they control 2 instruments, and 1 stays stationary wherever they left it last. So they can pull something up out of the way, maybe they're holding the bowel out of the way so they can kind of see under, and then they switch back to their other 2 instruments, and that arm just stays up there, so they can continue working. It's one of the ways that it gives them full autonomy, because they don't need an assistant. They can listen to themselves. Any other questions? Okay. Actually, before we go to the console, I'm just going to point out this tower here. So the 3 components, again, surgeon console, the tower here is our vision cart, and then this is the patient cart. This vision cart here has the screen up top, which allows the non-sterile member in the room to kind of have an overview of what's going on. It tells them which eye we're looking at. So these screens are 2D, so we're only getting input from the left eye or the right eye. As the surgeon sits down, they get both right and left like binoculars. That's how it gives them 3D. So whoever's non-sterile can see if it's left eye or right eye. They can do all sorts of troubleshooting there. They can adjust all the settings, so whether that's the microphone, whether it's the tint, whether if we're looking in Firefly. Have you guys had patients or surgeons ask you to administer IC green to their patients? So there's a way to toggle that on and off there. Do you guys know what that is? IC green, or why they would use it? To light it up, exactly, yeah. So it's a protein that binds to blood. It allows them to assess tissue perfusion. It also highlights ductal anatomy in gallbladders, so they can identify what's the cystic duct, what's not, so they're not clipping the wrong thing, which is a high-risk injury in gallbladder surgery, even straightforward. So they can toggle on and off from their console, or the nurse can do it from here. There's a ton of other stuff they can do from there. If you look on the bottom of the screen, arms 1, 2, 3, and 4, it's on this one and on that one as well. It also gives an indication of the arms that are being used. So right now we have arms 2, 3, and 4 being used. Arm 1, as you can tell, is just not being used, which is fine. And it tells them what the instrument is, if it's active, what arm it's in, and what hand is controlling it. And if there were to be a problem with an arm or an instrument is expired, a message will pop up directly above that arm. So on that screen there, the nurse can go over, read it, see what the problem is, if they need to call anybody they can. There's also the energy devices, or the energy generators there. They're used for bipolar, monopolar, and then what we call advanced energy. So that's like a vessel sealer that's using sealing devices, or we also have what's called a synchro seal, which is similar to a harmonic, but instead of using hot energy, it uses bipolar energy. So you can get real close to other anatomy. You don't have to worry about burning it, like a irritor or something. And then it's also where the scope gets plugged in, and then there are pedals down there as well. If a surgeon would like to begin laparoscopically, like say they're trying to take down adhesions or something, they can use the pedals to still use that generator before they sit down. Okay? And then this is our patient cart. It wheels in. These arms can be configured in any orientation based on the anatomy that the surgeon's going to be working on. The nurse will select it from the back, so based on what procedure they're doing, and then there's also a series of what we call targeting, so alignment that's done internally as well, based on maybe where something is located. And then they touch the arms. They can put whatever instruments they want in any of the arms, like I mentioned. They can trade them in and out throughout the procedure. These arms have memory as well, so if you need to take them out and clean them, they can put them right back into the same spot. And then usually after placing all this, getting it set up, then the surgeon goes and sits down. Any questions?
So for these types of procedures, you'll have, like, you would be here for each one?
Not everyone. So I typically work with surgeons who are navigating through the learning curve. They're just starting out with robotics, and then once they're all set, I don't come to all of them. I'll come and check in. Like, for example, Dr. Greenblatt is operating. He doesn't need my help, but I still pop in to say hi. See if they need anything. Any other questions? No? Okay, cool. Another thing I'm going to do once we have sit down, so I asked Dr. Greenblatt and Dr. Bortz why they use the robot, why don't they just do laparoscopic surgery? They're both very good at laparoscopic surgery, so what makes the robot different for them? The other group ripped up Dr. Greenblatt's response, so you guys don't get to see it, I'm sorry. He wrote something very nice. He also gave a nice blurb about why Sharp Coronado is his favorite hospital, which is very sweet, but we still have Dr. Bortz's. It's very small because I want you guys to see how zoomed in this camera is and how that helps the surgeon see different tissue planes, bleeders, and stuff like that to prevent any sort of mass injury. Okay, so I'll feed that to you once we go in. Why don't we all come over here and I'll give you a rundown so you guys can try it. Am I missing anything, Matt?
No.
No?
Perfect.
Okay. So another big benefit to the robot, especially during bariatric procedures, which again, surgeon Dr. Bortz does a lot of, those patients have pretty thick abdominal wall. So if you think about doing laparoscopic surgery, you know, they're standing over a patient like this, they're looking at the screen, they're trying to torque things around. It can be physically exhausting. So being able to sit down is helpful. And then each of the surgeon also has the ability to adjust the height and tilt of all of these things to be more ergonomically safe. And then they save it under a profile. So as you guys sit down, you can use those controls over there on the left side. You can raise or lower this thing. You just kind of want to be able to rest your forearms on it. This screen here, you can raise or lower. You can also tilt it. Open surgeons really like to look down as they operate. That's what they're used to before they did robotics, so they can move the tilt. Laparoscopic is the opposite. They're used to looking up at the screen. That's how they feel more comfortable. Surgeons have control, as I mentioned, for all the cautery and then what we call advanced instrumentation. So firing a stapler, doing a suction irrigator, vessel sealing, cutting, all of that kind of stuff. That's controlled by those yellow and blue pedals down there. Each one has a function related to the instrument that's in there. And then they also have control of their camera. So that camera pedal there, one with the camera on it, is how they can move the scope completely on their own. And how it works is similar to a newspaper. So they'll press and hold the camera pedal, and then if you're holding a newspaper and you want to see closer, you bring it close to your face. If you want to spin it, you can spin it, you can move it sideways, etc. So as you guys are playing with it, you'll probably need to move the scope around. Everything with this robot is a two-step process, so nothing happens on accident. The robot is never going to do anything on its own without a surgeon consenting to it probably 2 different times. And that includes getting started. So when you sit down, you're going to put your middle finger and your thumb, so not your pointer finger, but your middle finger and your thumb through these white discs like this, so you can pinch down, kind of maneuver them like this. And you're going to leave your pointer finger out so you can pull back on this gray tab. And what that just allows you to do is reposition your hands, your actual hands, without repositioning your instruments. So it's kind of like picking up your mouse on a desktop or something like that, because you'll find yourself reaching and you'll say, why can't I go more? It's because you just need to pull this and bring it right back. So you're going to put your fingers in, and then you're going to put your head in. So once you put your head in, there are lasers right here, and the robot can tell that there's somebody in there. So if I just walk by and I move this, those instruments aren't moving at all. There's no way. So you have to have your head in there in order to take control of the instruments. So put your hands in first, then you put your head in. Once your head's in, you can pinch your fingers together a couple times, quick pinch, 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 and then you'll have control of the instrument. You can move it around. Okay? Any questions? Who wants it first? Sure.
There you
The throne
go.
is yours.